Now, moving on to our first section. First is the assessment of the airway. As you know, in this trauma, the first thing is A, B, C, D, that is the airway and the cervical spine. So we'll be briefly going through how to be aware of the problems, how to recognize them, and how to manage them. So that is actually the systemic management depends upon the logical progression of the examination, then use of ARM system, that awareness, recognition, and management system. What is awareness? Use history and accident mechanism. For example, a patient was thrown out of the car, then probably not only there will be glass which will be going into the facial trauma, there may be associated pharyngeal or laryngeal injuries, but the patient may be having a cervical spine injury as well, because when the patient was thrown out of the car, that actually dictates what are the possible mechanisms which could be problematic. For example, if the patient is having no injury but there are seatbelt marks, we should be suspecting blunt chest as well as abdominal injury. So actually history and accident mechanisms gives us a clue that what could be the possibly wrong with the patient. That is, predict likely injuries and anticipate problems which could be associated with the airway and cervical spine. Then is recognizing them. For example, if you are examining a patient and patient is not responding, this means if the patient is unable to tell you his or her name, that means most likely the patient's airway is choked or it's blocked, and one must consider securing the airway. Cervical spine is said to be protected until unless proven otherwise, that once we are sure that there is no associated cervical spine injury, keep cervical spine protected. So this is how you first be aware of what could be wrong, then you recognize, and then you move toward the management. That is using look, listen, and feel sequence. This is the sequence with any examination, and identify physical signs of injury, which could be like if we are dealing with airway, there could be hoarseness, there could be labored breathing, there could be blood which could be coming out of nostrils or mouth, or there be laryngopharyngeal trauma, there could be labored breathing as well. So we have to be very active in our approach, that we have to be aware, we have to examine, and then we have to manage accordingly. Once we identified injuries, then again the management starts with the ABC, that is the airway and the cervical spine first. After implement most effective intervention is first, and ABCD format is always followed. That is airway, cervical spine, then breathing, then circulation, then the disability goes for the neurological assessment, and then lastly the environment and the temperature. Now coming on to airway and cervical spine. Airway is secured and protected, and cervical spine can be initially secured by inline immobilization. That is, you keep paramedics keeps both arms along with the cervical spine area, so till the soft collar or hard collar is available. Stiff collar is usually used, but it makes a bit intubation difficult. But nowadays, good quality stiff collars are available, by which intubation can also be done easily. Maintaining a neutral position, one must consider when we are protecting the cervical spine, there must be no hyperflexion or hyperextension. And usually the stiff collar, head blocks, and tapes can be used, but most commonly stiff collar is more than enough to immobilize the cervical spine. Now coming to CT scan and MRI, these are done only when we are sure the primary survey has been done and patient is vitally stable. Usually even cervical spine x-rays are not done in the primary survey, because first we have to rule out all the possibly life-threatening injuries. If they are done, keep cervical spine immobilized. Once the patient is stabilized and we are suspecting some kind of injury, then we can go for CT scan or MRI of the cervical spine. Now coming to the awareness, what causes actually the airway obstruction? This could be head injury, which causes airway compromise. It could be pharynx collapse around the glottis. It could be supine position in which the tongue actually drops backward and actually chokes the airway. Or it could be a sudden airway obstruction due to edema or anything like that. The other causes include maxillofacial trauma, because disruption of the facial bones and compression of and obstruction of the pharynx can cause airway compromise. There could be soft tissue swelling and bleeding, which may be actually choking the airway and obstructs the airway. It could be neck trauma, which could be penetrating and blunt, causes hemorrhaging and swelling. and distorts and obstructs the upper airway. So supraglottic airway is blocked, then still the patient will have an airway compromise. Tracheal intubation is sometimes impossible. That is why, for example, if there is supraglottic trauma or laryngeal trauma, then what happens is that ETT cannot be passed. Then we may have to go for definitive airways such as tracheostomy to keep the airway patent. Now, coming to other causes, as I told you, it most likely could be a laryngeal trauma. There could be blunt force trauma from the impact, which disrupts the larynx and fractures of the cartilaginous structures, which may not be visible on X-ray, and immediate airway obstruction occurs. This is usually associated with hoarse voice, coughing of red blood, and this usually swelling around the neck, which give telltale signs of a laryngeal trauma. The patient may have not any kind of a trauma, but patient can have inhalational burns problem. What happens is as hot gases actually move through the leg, this not only disrupts the normal structures but also causes massive tissue inflammation and singing of the hair. This could be swelling and airway obstruction due to edema, especially the laryngeal edema. Facial burn and smoke staining may be present and can be seen on the face. Seeing nasal hair may be visible, and patient may be having a labored breathing and problematic issues with the airway. In this, if you pass the ETT well early before the edema sets in, it's good. But if it's not done, then probably later on, once edema sets in, laryngeal edema makes ETT, passing of ETT highly impossible, then we may have to resort to tracheostomy. So then, because ETT and definitive airway cannot be secured. Then coming to recognition of it. Recognition, the method and formula is always the look, feel, and listen. That is, agitation, aggression, anxiety may be seen in the patient, that may be due to hypoxia. It could be obtunded conscious level, patient may be drowsy, or hypercarbia may be present in the patient because there is actually retention of CO2. Blue discoloration cyanosis is usually only seen in a very advanced stage. Early on, this may not be very much visible. Increased autonomic activity, for example, sweating, anxiety, and restlessness may be present in the patient. There may be flared nostrils. There may be tracheal tug or intercostal traction, which may be seen on the examination as well. These all signs indicate that the patient has most likely an airway obstruction. Now coming to the what to listen for to rule out airway obstruction. We have to look for the noisy breathing, stridor, hoarse voice, or absence of noise, or airway obstruction or apnea. Then what we have to feel for, that is air passages by mouth and nose using the palm of the hand. Palpation of the trachea is very important because if the trachea is not central, this means this mostly could be underlying a tension pneumothorax. So we have to palpate trachea because there is not any associated tension pneumothorax developing. There could in the suprasternal notch and deviation, as I told you, associated with pneumothorax. Now once we have done, we have looked at it, we have listened to it, and we have the next steps felt it, then comes the auscultation, and when auscultating, we have to actually look for the breath sounds and all those maneuvers. Now, if we are suspecting that the patient has an airway compromise, what are the maneuvers we can take to restore the airway? Could be simply bare hand maneuvers, means chin lift and jaw thrust. That is the only thing you can do with the bare hands. Then it's usually sniffing. Early morning air position is not always indicated because the most likely the spine should not be hyperextended or hyperflex. It should be in a neutral position. Supraglottic airway devices such as laryngeal mask airway is helpful, but only in certain areas, because we eventually have to move to restoration of a definite airway, and that is either by endotracheal tube or by tracheostomy. No surgical airway maneuvers usually done for children because their spine is already slightly hyperflex, so we have to manage it accordingly. Now coming to the maneuvers which can be done. As I told you, there are two maneuvers. One is the chin lift and the other is jaw thrust. Chin is lifted forwards at casualty head or side, pulls jaw and pharyngeal structures and opens up the airway. Actually, the pharynx and the actually tongue drops backward, which actually obstructs. And so chin lift helps to clear the airway because the pharyngeal structure is actually pushed forward. about the jaw thrust. Is more assertive maneuver is effective in those with the small jaws or thick necks in using thinner eminences. Application of pressure of the jaw thrust actually results in opening of the mouth and so that the airway can be cleared. Bag valve mask assembly for the ventilation of lung can be utilized and can be used before the definitive airway is secured. Now, in this section, we have gone through a very important topic, that is the first how to assess the airway and cervical spine. As you know, in any trauma patient, the first and foremost starts is the A, that is the airway and the cervical spine. Cervical spine must be mobilized until unless proven that there is no injury of the cervical spine. And usually the first thing which comes in the primary survey is the securing of airway, which could be by the use of simple maneuvers, that is jaw thrust and chin lift, and then passing of the oropharyngeal airway. Thank you very much. Keep watching sqadia.com.